So these are my disclosures. I think I've been involved in a variety of pharmaceutical companies that have studied in this space. I have two messages, hopefully for you all. The first is antiplatelet therapy for vascular disease is not enough. I think we'll go into that, and then I'll talk about how we can integrate antithrombotic. So misconception one, as cardiologists and some vascular specialists for a long time, we've said more antiplatelet therapy is better for coronary disease and PAD. So let me walk you through why I think that's misconception one. This is a review that a partner of mine, Dr. Jones, and others did. And really on this slide, you can see that there's a variety of things you can do to inhibit thrombosis. And at the center of the slide is the platelet. And so if you think about clopidogrel, prasugrel, ticagrelor, cangalor, Vorapaxar, aspirin, we've spent a lot of our time thinking about how to inhibit that agent. We didn't spend a lot of our time thinking about how to inhibit thrombin or the conversion of fibrinogen to thrombin, because it was warfarin only. Now, of course, we have 10A inhibitors, and soon enough we might have some 11A inhibitors. So it's important to think about. So why is antiplatelet therapy not enough? Well, it's older data, but Capri would have told us that yes, clopidogrel in broadly defined vascular disease, including PAD, CAD, it was better than aspirin, but not by much. A 0.5% absolute risk reduction and 8% overall relative risk reduction. The PAD group in the bottom right is positive in that group, as you can see. I participated with many of you all and others looking at Euclid, where we took a stronger antiplatelet agent, ticagrelor, compared it to clopidogrel in patients with PAD, 14,000 patients for the primary endpoint of cardiovascular death, MI, or ischemic stroke. And after 3.5 years, we were disappointed to find that not only was the rate of MACE, CV death, MI, and ischemic stroke 10% in both, almost exactly the same hazard ratio, flat 1. If you look at the key secondary endpoint of MACE plus acute limb ischemia requiring hospitalization, again, very similar. And these were patients that had ambulatory PAD with claudication, but certainly about 40% of them had had a prior revascularization. So I would say another message for me, at least in that space. So the conclusions of monotherapy, antiplatelet therapy, and at least in the space for me, is that aspirin versus placebo, I didn't show you this data, it crosses unity, but it's a little bit better than placebo in PAD. Capri's a little bit better than aspirin. Euclid showed that ticagrelor and clopidogrel are pretty similar. Well, what about 2 versus 1? A lot of people think about that. So charisma, again, in the broadly defined vascular population, aspirin plus placebo versus clopidogrel plus aspirin, the hazard ratio crossed 1, and it did show a reduction, but again, not a very robust reduction. What happens in practice? Again, Dr. Jones and others looking at it, and in our organization, others looking at Medicare data, all patients undergoing peripheral endovascular intervention. This is a little bit older data, but this is in Medicare with Part D, 85,000 such patients. 25% were on DAPT greater than 30 days. 20% were not even on a P2Y12 inhibitor prescribed after revascularization. So our practice varies dramatically in what we do for our patients undergoing endovascular revascularization. We can talk about what might be better. So I guess I would say the new learning based on COMPASS and other trials I'm going to show you is that if you can get the right dose of an antithrombotic that's working on thrombin and an antiplatelet, these patients might significantly do better. So let me just remind you the COMPASS trial design. When this trial was designed, I would have told you that I didn't think it was going to be positive. It's really hard to win in chronic stable CAD and PAD and show that you can be better than aspirin. This trial looked to take those patients and randomize them to aspirin, rivaroxaban 5 milligrams BID or 2.5 plus aspirin. If you look at the trial, just to remind everyone, it was stopped early for a mortality benefit, and the DSMB stopped early because of overall cardiovascular reduction benefit. And when you looked at the 2.5 milligram dose, which you can see on the bottom, there was a significant hazard ratio reduction of 24%. Absolute risk reduction starts to get towards 1%. I'll show you more of that. This is the composite in the entire population for CV death, stroke, and MI. And obviously, each of those is trending or positive and consistent with the trial that was stopped early and pretty robust. If you would have told me before the trial started that in PAD and CAD patients, low-dose aspirin plus a little bit of low-dose rivaroxaban was going to have a 50% reduction in stroke in non-AFib patients, I would have again said, that's unusual. I didn't anticipate that, or cardiovascular death. And when you look at stroke, MI, acute limb ischemia, now thinking about our PAD patients, and you look at death from any cause, if you go down this chart, you continue to see fairly robust efficacy. So I'll say very few therapies do I have for my patients with PAD where I'm going to not only affect potentially the limb, the brain, the heart, but potentially all-cause mortality. Here's CAD and PAD together. So one thing we know is patients with PAD in this trial, they had polyvascular disease, so they often had coronary disease too. Their event rate is higher, 5.1% with Riva plus aspirin versus 6.9%, but a relative or an absolute risk reduction that's still over 1% and a hazard ratio of 0.72, so pretty robust. There's no free lunch, so I think everybody would say, what about bleeding, Manesh? What's that look like for this population? So I do want to make sure we look at bleeding and say, this is major bleeding. It was a modified ISTH. It does look like it's increased, a hazard ratio of 1.70, about a 1% increase, but no real change in fatal or ICH bleeding, but still an increase that you'd have to think about. Obviously, it didn't affect all-cause mortality. I guess for our PAD audience here today, how about the limb events? First therapy and randomized function, I guess, would say, in addition to having a MACE benefit that has a male and major amputation benefit, male here included significant severe ischemia leading to revascularization, major amputation. And not huge numbers, but it is a 20,000 patient study, and you can see a 1% again, or a hazard ratio of 0.54, so 40% reduction. So I think pretty powerful. Some of you may know that the ongoing Voyager trial is testing the same dose. This is randomizing patients after revascularization, either surgical or endovascular, and patients are getting that regimen versus aspirin. Interestingly, we've collected the devices the patients are getting in this trial, and a certain percentage of these patients, probably 15, 20%, will have drug-coated devices. We'll be able to tell you how those patients did in follow-up. We're also going to have, obviously, not just, this will be the first vascular trial where it's not just MACE as an endpoint, but there'll be also male or at least acute limb ischemia from ischemic causes. So how do I think about the world from Euclid, Compass, Voyager, and other things? I guess early risk for our patients, certainly there's still a benefit for antiplatelet therapy, but as that antiplatelet therapy and chronicity comes, it doesn't seem like chronic antiplatelet therapy has bigger benefit as what I've shown you with the dual antithrombotic therapy with a low-dose antithrombotic like rivaroxaban plus aspirin. And early on, we're going to find out if in Voyager or other trials in our PAD population, can you rotate them even faster? So trying to stay on time, I'll tell you, these are my conclusions and at least my current therapy for patients with PAD. I believe the best current therapy for chronic PAD does include dual pathway inhibition, and these are patients that likely have had PAD and polyvascular disease and are out from their revascularization some period of time, 6 months, 8 months. In the entire drug-coded conversation, we haven't been talking about what the medical therapy is, how many of those patients in practice who are surgical patients have a vein, have something else that's thrombotic. So I would say this is the therapy I think would certainly be something I use in my polyvascular patients. Post-revasc, I'm still using DAPT for 3 months, based mostly on opinion, not great data, and then thinking about transitioning those patients. And we await, obviously, the findings of Voyager, which I think will inform us as that ends this year into next year. Thank you.